Three, two, one. Hey guys, welcome back to the Foam Frat podcast. Tyler and Sam got a cool episode today. I interviewed my buddy Alec Wilcox from Lifelink 3. We talked about the eligibility for ECMO, preparing for ECMO, initial eligibility compared to maybe once you get to the bedside and they get gases and they don't meet those markers. Sam, you watched the episode. What were some of your thoughts?
The thing that caught my attention the most was talking about 30-2 versus continuous chest compressions. And this has been something I've been curious about. You and I were chatting a lot about this when we were at Echo and we were hitting up the what booth were we at? The Hamilton booth, and talking about how do you can you synchronize the ventilator to the Lucas so that you can kind of still do this automated resuscitation. Because that's kind of the whole, that's one of the biggest benefits of having the ventilator and you have the Lucas is you can kind of just not set it and forget it. But I mean, things are pretty automated. It frees up some hands for sure. But when you have to time out the CPR with the ventilations, then it does take some of that cognitive bandwidth. And so you'll have to humor me for a second, because maybe these numbers are maybe everybody's really aware of this, but I never hear this conversation occur. So you just tell me if you've heard this one before. But so if you're doing continuous, we'll assume that you're doing 120 compressions per minute because the math is a little bit easier. Okay. So I was writing this out. So if you're doing 60 seconds of CPR straight and you're doing one breath every 6 seconds because you're doing it continuously, and assuming this is all, you have an endotracheal tube placed or whatever, that means that you're getting 10 breaths at pretty high pressures. You guys talk in the podcast about how you're fighting the chest compressions on the way in, which is pretty large swings. So you're messing with the peak pressure settings and you're delivering it a certain way and stuff. And so there's really unless you're doing your pulse check, there's really no time off of the chest. So that means your chest compression fraction is practically 100% unless you're doing a pulse check, right? So that's pretty high, but you have these once every 6 seconds, we'll just assume it's a second for the breath, a 1 second inspiratory time or something, right? Mm-hmm. So you have 100% chest compression, but you have 10 of these breaths per minute. When you're doing 30-2, assuming that you're doing 120 compressions per minute, that means that that's 2 compressions per second. So over the course of 15 seconds, that's your 30 right there, right? So you get 30 compressions, that's 15 seconds. And then the time that it takes to do the breaths, right? I would assume the fastest you could probably do that is about 5 seconds, right? If you're doing 1 second in and even 1 second out, 1, 2, 3, 4, and there's a little bit of coordination time on both sides, and that's pretty fast for an exhalation, right? So if you were to really squeeze that down, at the best, you're getting 15 seconds for the CPR and then probably a 5-second break. So that gives you these 20-second blocks, right? And so you can hit 3 of those within a minute. 15 seconds CPR, 5 seconds breaths. Repeat that 2 more times, that's your minute. So over the course of that time, if you're doing 3 rounds of that, then you're giving 6 breaths over the course of that minute. So you're going from 10 now down to 6 if you're doing 30-2, but they're also low pressure breaths. So it's not as much intrathoracic pressure, very likely. There's way fewer of them, assuming that you're doing this timing. But when you do that for the chest compression fraction, again, assuming that, maybe your pulse check would be about the same amount of time as what you do for the breaths, right? That's 15 seconds off the chest per minute. So that means that your chest compression fraction, just rounding these out a little bit, is 75. So you're looking when you compare those 1-to-1, it's 10 breaths under high pressure versus 6 breaths at lower pressure. But apparently, if someone's making the claim, and there's evidence out there that the 30-2 is at least the same, or it's better, maybe, right? That would mean that the difference in those amount of times that you spend at that positive pressure is worth 25% of your chest compression fraction when you're looking at pretty much 100% versus at the best 75%. So that just made my brain start working. What if you decrease the amount of breaths when you're doing it, synchronously, you're having the Lucas just continue to go, and maybe you do a breath every 10 seconds at lower pressure or something like that. Would that offset those? So my brain has just been going crazy with these numbers, and I don't know if that was maybe that's something everybody's supposed to just imagine when you're learning BLS or something like that, or ACLS. But I don't know. We've talked about this quite a bit. What are your thoughts on that?
Yeah, the biggest concern, and Alec did a great job of pointing this out, is that the breaths that you're giving are just dead space ventilation. You're not actually clearing any CO2. Your actual alveolar minute ventilation is poor, so you don't have good oxygenation and good CO2. And maybe in the first couple minutes of an arrest when you're just doing compressions and getting your first defib in, whatever. But when you're working these arrests up to an hour, that becomes obviously very important to clear the CO2 and to oxygenate. And so my thought process had always been that as soon as you stop doing chest compressions, it's just like this, boom, you just drop, right? Your diastolic pressure drops, your coronary perfusion pressure drops, and then you get back on the chest and you're just trying to rebuild back up enough of a back pressure at the coronary ostia to perfuse the heart. And the more research that comes out about this, the less that is the case. And so you do have a little bit of time. Now, whether that takes 5 seconds, whether you're 3 seconds, either way, it is going to cut into your chest compression fraction a little bit because you're taking that time off, you're getting those breaths in, but then you're getting right back on the chest. So I hear it is a sacrifice, right? It definitely is a weird thought process to say, hey, maybe we should be doing, 30 to 2. But I would say the main reason you're probably doing 30 to 2 in the beginning when you're even before you have an advanced airway in is just because you're like, I'm using a BVM. How much of this air is actually even going in? I got a crappy seal. Once you drop in an advanced airway, and we talked about, not to spoil it, but an endotracheal tube is going to be better in the long term. In the short, yes, you can use an eye gel or something just to get a better seal on the mask. But all of these things are it's just interesting. Cardiac arrest has been one of the most interesting things to watch throughout just my EMS journey because it goes from, let's use IOs, and then, actually, there's better chances with an IV, and maybe we should get an endotracheal tube right away. Well, actually, the PART study came out, and the airways too, and it says supraglottics are better. And the main thing I realized with all of these is they're all so dependent on the demographic, which resources are available, the training, right? I mean, if you want to do a large airway study, you go recruit a huge municipal fire department. But are those going to be the people that have the best first pass success rate? Maybe not. So that's the thing that's hard with a lot of this. But I saw when I went to this ECMO conference, and I won't say the name of it or whatever, but there was just one after the other, just 30 to 2, 30 to 2, 30 to 2. A paper came out, 30 to 2 is better for the patient, but it's harder to essentially stick to the protocol.
That's the one I was just reading, yeah.
Yeah, because it's hard to adhere to because of exactly what you're saying. And I remember you gave a talk one time on just the future of medicine. And you're like, isn't it weird when you walk into an ICU room and you got all these machines and none of them are talking to each other? So maybe eventually that's what we see. If you are going to use the CPR mode in the Hamilton, you just got to watch those exhale tidal volumes. And so I would like to see someone who knows how to work that vent, right? They know how to adjust the flow rate to turn it off, and they know how to play with their pressures, and they're conscious of those VTEs if there really is that much better of a trade-off between that and the 30 to 2.
Yeah, I would like to see something where it's one breath. I would like to see how different it is if you use the same respiratory rate from the 30 to 2, which is like 6 breaths a minute, what it comes out to. And if you did that on the vent, instead of doing it once every 6 seconds, if you went to once every 10 seconds, if that would get you within the same ballpark, or if it really is those breaths trying to go in at the same time of the chest compressions, that's always going to lead to an issue. So I walked away from this. The data is pretty not robust, but there's some pretty strong data out there about it. But I would be interested to see where those two meet. Like how much adjustment do you need to do on the continuous chest compressions to kind of get you in the same spot as far as outcomes go with the 30 to 2, so that it can be synchronous until these machines can pretty much talk to each other. But yeah, I thought that was an interesting point that kind of goes into, it's about ECMO, but it's like everybody does CPR. So I just thought it was an interesting point.
Awesome. All right, let's get to the interview. All right, so I'm with Alec Wilcox here from Lifelink, and I cornered him into letting me pick his brain on a couple things regarding CPR, who is an ECMO candidate, what should we do differently if we think they're an ECMO candidate, and the eligibility, bedside eligibility versus the initial eligibility. So maybe they were, but then they get there and they draw gases and they're like,
Sure.
This is not something we want to do. So let's start off with the basics. So I go out, I got a patient that I'm thinking they may be a candidate for ECMO. They're in arrest. What does that look like? Is there an age cutoff? Is it after a couple shocks I should start thinking about it? Like, what does that look like?
Yeah, I guess when I go on flights and I get dispatched lots of times to like those cardiac arrests or something like that, like some of the auto launch areas that we go to those cardiac arrests, I start thinking about age. Normally, the age range for a lot of studies have shown, and what most of, especially in our area, the Minneapolis area, with a couple of ECMO centers and ECPR centers, is that age around 75 is that upper. I mean, that's a soft kind of age range. It's more like, how do they look? Because as we all know, like the age can kind of fluctuate a little bit. Yeah, 100%. So if you have somebody who's 76 but goes and runs still, like I would still definitely make a call at that point. So I think around that 75 age, and then dropping down to around 18, 17, that age as well as and everything, especially comes into play as with some like cold water drownings and stuff like that. ECMO can be beneficial for those patients. You already brought up the comorbidities is really important. So making sure they're not like a skilled nursing home patient in that resort. And then really just optimizing your time on scene, trying to cut all the time out you can on scene is kind of how I start. I try to get that report ahead of time a little bit more than I would on some other scene calls. So seeing if it's a witness arrest is really important. What that initial rhythm was. This VFib VTAC has the most evidence for beneficial. PEA does have some periods where it can be beneficial. However, it's a really short time period. So that's why primarily it's that VFib VTAC. The patients that are also really beneficial are the ones that have intermittent periods of ROSC. They just keep rearresting everything. Those are great, and the patient's able to oxygenate well during those times and can help extend it, which is what we're up against in the pre-hospital world.
And like, we're talking, it kind of sounds like you're talking in like you're coming in flying to a scene flight, right?
Yeah.
But this could also be someone who's responding from an ambulance who gets there. They're the first ones walking in and they're like, hey, this may be a patient that is an ECMO candidate. Like you said, maybe the initial presenting rhythm was a shockable rhythm. And so, if coming in from like the aircraft side, you kind of have a little bit more of a heads up as to, yeah, we've shocked him multiple times and you're talking with comm. Hey, is there ECMO bed available? What's the status with all that?
Sure.
And so they get on scene, they have a presenting shockable rhythm initially. Do they have to say like, hey, we had a couple shocks and they all failed before they can deem that patient a possible ECMO candidate? Is it one failed shock? If they shock someone and then they come back and now they're in like a PEA, does that remove their ability to be an ECMO candidate?
No. So one shock, any one shock that has failed where they don't immediately get ROS after that one shock is an ECMO candidate.
Okay.
And even backing up kind of step before off for a 911 ambulance service or something like that, or first responders or PD, this is all applicable too. If you have somebody who is a witness arrest, like they say it was in a public place or at home, it's witness and immediate bystander CPR, those are patients that I would be calling even before getting on scene. At least giving your ECMO centers a heads up that you have a patient that is a potential. Because if they likely were a witness arrest, like say somebody arrests at a gas station or supermarket or something like that, commonly they're going to be MVT-VF if it's witness and it's no downtime. There's probably going to be somebody around who knows CPR or 911's instructing it, and then there might be an even AED there. Especially we're so lucky with having AEDs on a lot of our squad cars. If you see a note get entered into the CAD that says AED deployed and shocked, that's an activation right there. You don't even need it on your monitor.
And I mean, their best chance from what we've seen with the evidence is like those first couple shocks is where the majority of them are going to come back, right?
Yeah.
And then there's like your chances slowly decrease as you sit on scene and you keep shocking and shocking and shocking. And so, you know, while this isn't a resource everyone may have available to them, when it is, there's a little bit of a paradigm shift because we're taught, don't just throw them in the back of the ambulance and run, but do your job there. Your compressions are going to get worse when you put somebody on a cot and you're doing one-handed CPR on the way to the ambulance. And so that has to be a little bit more of a mental shift to say, hey, we think this patient is an ECMO candidate. We've already done our stuff. You know, we have an airway in, we're ventilating, we're shocking. Would you say that, you know, what should be the trigger point? Is it after the first couple epis, after the first couple shocks? Is it after you give your amio? Like if you and I were on a 911 truck and we go into this person's house, the wife saw the guy go down, she's doing CPR on him. We walk in, we start doing CPR, we put the pads on, we see he's in a shockable rhythm, we shock him, get right back on the chest. I drill them. You know, you're putting an airway in. When in that event should we say, let's get moving to the truck?
Yeah. I think for a lot of those scenarios, the earlier the better. If you are in a service area that has access to an ECPR center, you should be trying to optimize as much as you can en route. That doesn't mean we shouldn't still provide a good high level of quality care, but that can involve just placing an eye gel real quick on scene, not opening your whole intubation room, just placing your eye gel right in the patient, drilling, and one shocking the patient and going. Because the thing I always like to talk about is there's great evidence that has been shown across multiple ECPR studies that like time is everything for these patients. And if you're already behind the 8 ball because there was a 911 call, you have your dispatch time, you have your response time, like you're at least 10 to 15 minutes already in there. And then you're going to have at least probably another 10-minute scene time is reasonable to get somebody on the backboard, get them in the ambulance, secure them, and get going. And then a 10-minute drive, you're talking you're at least 30 to 40 minutes under best case scenarios with no other limiting factor. So especially with Lucas CPR now or Autopulse CPR, making sure you have a mechanical CPR device on there, provide a reliable, consistent care, and be
Would you say that's required?
I would say it's not particularly required in essence. If you are still able to provide high quality CPR, that is applicable for patients who don't fit in. If you have somebody who's in a shockable rhythm who is witnessed but might be a little too large for the Lucas, I wouldn't say that's immediately a disqualifier from pre-hospital ECPR. The real risk primarily is towards you of being an unseatbelted provider in the back of an ambulance. It's your safety.
And how good are those chest compressions going to be?
100%.
And like the arrest trial, that was one of the requirements. They had to have a mechanical CPR device. And so, I would say that, you know, while you don't want to say, hey, we're just going to sit here and wait for this rhythm to deteriorate into asystole, if you are going to put yourself at risk and you're not going to be doing that good a quality of chest compressions, I mean, that's got to be a real pivotal like decision point right there.
100%.
What's in the best interest of the patient? And, you know, if they are that large, what comorbidities are there as well? Are they going to be someone who bounces right back? So all things to consider. Now, you mentioned just dropping an eye gel in, right? Now, Jason Bardos put out a study, you know, et al., some other people as well, looking at the oxygenation, the initial PaO2s, PaCO2s when they came into the ECMO center to get put on pump. And they saw that the patients who were having supraglottic airways were not meeting those gas markers as well as the patients that are intubated. And at the surface, that makes sense, right? Now, my interpretation of that is, the first crew that's going in that has to get all these things checked off really quick, they can put an eye gel in, right? Make sure you're suctioning, make sure you're doing all the stuff you should and not just jamming food boluses down with your eye gel. But if you are a flight crew that's picking up a patient and taking them to ECMO, the CPR is already happening, right? They're probably already on the ventilator, or, you know, you're bagging them. Would you suggest at that point, if you are the flight crew, switching out the supraglottic for an endotracheal tube?
Yeah, I would suggest that for ground EMS as well. I think you hit the nail on the head perfectly of when there's everything else going on and you're trying to get that patient out of the house and you're trying to have less than a 10-minute, 15-minute scene time to get this patient to an ECPR center. The iGel is able to provide those good ventilations for that short period before. But there, as Jason Bartos did put out that paper, which was very interesting, the endotracheal tube does provide better ventilation, and oxygenation, I think, was pretty obvious. And I think that's something a lot of us probably knew who have worked in critical care or ground EMS for a while, that with that. But I do think that is something during your drive to the hospital that can be switched out. You can switch out that iGel to the endotracheal tube and optimize those ventilations and oxygenation due to this arrest being prolonged. I came from the period of working as a paramedic where we would work it for 20 minutes on scene and you terminate. Now for almost every ECPR I've been a part of, it's been well over 20 minutes till the cannulation. So maybe the iGel was able to provide good ventilations for a short period and able to get the patient through. But the endotracheal tube, I think, as that paper showed, really optimizes the ventilations, and you're able to do it en route for these longer arrests that ECPRs are in nature.
All right, so let's talk about something that's maybe a little bit more controversial, but the ventilation aspect of it, right? So I was always of the mind as to why is manual ventilation with the BVM the standard when it comes to cardiac arrest, right? As soon as somebody would go into cardiac arrest in a hospital, the first thing they would do is what? Disconnect the ventilator and they would bag them. And so we've gotten in the practice here of putting them on CPR mode on the Hamilton, making sure that your flow trigger's turned off and trying to dial in the settings, watching your exhale tidal volumes. Because ideally when we get them to the cath lab to go on ECMO or wherever they're going to get put on ECMO, we don't want their lactate to be through the roof, PO2's down in the toilet, and CO2 is sky high, right? Because that shows that maybe the 60 minutes that you've had this patient, or, you know, the time from initial arrest to whenever, that they're not adequately ventilating. So you're like, okay, well, maybe we'll put them on pump and get the heart back, but is the brain going to come back as well, right? And so now I went to the ECMO conference and they were talking about different topics within transport and ECMO and pre-hospital stuff. And they mentioned this 30-2, right? Even after you have an advanced airway in. And I kept hearing that over and over again. So I have an ET tube in. I have a ventilator right here. Do you think that the patient's going to get better ventilation, oxygenation, if I do 30 compressions, then stop and give 2 breaths, and then get back on and do 30 compressions? Do you see validation to that? Or do you think that this really we don't have any sufficient evidence to support that?
I think that was something that came out of that paper that you talked about, was that different ventilation. I think there's a couple different parts to it. I think with an endotracheal tube, or I guess I'll back it up. Starting with 32 versus continuous compressions. I think in watching it on the ventilator is that watching the ventilator deliver breaths during compressions is, I think, something that requires some real nuance of ventilator management. Because I think you very easily can get caught in a scenario where you're grossly under-ventilating these patients. Especially with like the Lucas CPR providing such good compressions, there's a lot of breaths, like as we talked about the CPR mode, it'll pressure out at 40, right? Then like if you have a plunger down on somebody's chest and maybe they're a little larger, already have adipose tissue, they're not well recruited, you're going to easily hit 40 PIP without issue.
So you're going up on your pressure limits.
Yeah, but you got to be careful as well, because
you got to watch that.
Yeah, I mean, very easily you can tension somebody off if you start cranking them further up, especially if you don't know what the underlying status of their lungs are before this, like were they fragile COPD, or who you could easily pop air sac. So I think sometimes the BVM can be easier on that way. I think watching and getting chest rise is easier with the BVM on 30-2, because you have those 2 designated pauses where you don't have a Lucas CPR. They're just periods where the only thing you are doing is giving breath. So if you're able to use that BVM and look and see chest rise, go back down, look and see chest rise, you know you're getting adequate ventilations at that point. Versus the ventilator, it really depends on if you time it right with the compressions. So my preference is I do 30-2 ventilations because of that primarily. I think there's also a vast difference between the pressures that you can push through an endotracheal tube ventilating somebody when we're talking about PIP airway pressures versus a eye gel.
Yeah, I agree. Yeah.
Yeah, I think the eye gel, just by the nature of it being an LMA style device, doesn't provide as good a seal.
Mm-hmm.
So having an endotracheal tube that has a balloon, I think you probably can overcome some of those more pressures and get better ventilations with intermittent compressions with intermittent ventilations with an endotracheal tube versus an eye gel. But I still think the 30-2 is a better time to optimize ventilation and compression. It's a better strategy.
And I happen to know, like, you've done that in the helicopter,
Yeah,
right?
yeah.
So are you having the Lucas just in that 30-2 mode? And then when it stops, you give the 2 breaths and then it kicks back in again? Are you keeping the vent and just doing 2 manual breaths?
I'm just using a BVM, honestly, and just watching it. I think obviously you can't hear it, but just pausing it, you're giving those 2 breaths on the pause. I personally don't think
Are you hitting pause or are you letting it pause?
letting it pause.
Okay,
sorry.
yeah.
Just a normal 30-2 standard mode that's on the mechanical CPR devices, the Lucas that we use, and just giving those ventilations during that period. Yeah.
With that, so what's interesting is I was talking to, I won't even mention that. I was talking to a physician the other day, and they were talking about how, like, our mental model of when we stop CPR, we think that the diastolic pressure, the aortic pressure just plummets, right? Just boom. But from some of the pig labs and some of the studies, that doesn't necessarily happen, right? Now, while you shouldn't have all these unnecessary interruptions and chest compressions, to stop and give 2 breaths and then begin again, it's not like, oh my God, now I got to start all the ways back up with building enough of a pressure head to have enough coronary pressure, coronary filling pressure. And so the 30-2 makes sense to me, Now, do I wish that we could somehow make the Lucas and the ventilator talk to each other so that way it would stop and then give 2 program breaths and then get right back on the compressions? Yeah, but I do think if you're just doing 2 breaths with the BVM, you're doing it to get chest rise, those breaths are going in, as opposed to watching a ventilator, seeing your flow waveforms, and you see the flow like this, but you see it's not triggering a breath. And then every once in a while it triggers a breath. But yeah, maybe you're getting a breath and that piston's coming down on it at the same time. So it does make sense to me. And I think it's something interesting. Now, obviously, like, people listening to this follow your local guidelines, right? And,
Sure.
and AHA does say once you have an advanced airway in, it's like 1 breath every
6 seconds.
Yeah,
And they count the eye gel under that as well.
Right.
Yeah.
Awesome. All right. I had a couple other things I wanted to mention. The other thing I wanted to discuss is, I have this patient that is an ECMO candidate, and I'm going to ECMO, and they're still in this VTAC VFib. And I've shocked them multiple times, right? At what point do you just stop shocking?
I think on a pre-hospital ECPR patient, I don't think there is a point in which you stop shocking. I do think doing the same thing repeatedly is probably not best. But like once I start having multiple failed shocks in this patient's in refractory VFVT, I think that's when I start doing my vector changing, anterior, posterior, changing to different orientations. If you have access to a second AED, the dual sequential, I do think there's the New England Journal of Medicine came out with published an article recently that had some good evidence for showing both vector change and dual sequential defibrillation helping with that. But I don't think pre-hospitally that there is a point in which later down the line that might be something to decide once the patient's on ECMO. But I don't think you are going to get enough shocks in the time period in which somebody is a candidate for ECPR where you can be concerned with any of the issues that shock.
So you would just keep shocking?
Yeah, I would keep shocking it, try different vector change, try dual sequential.
Even though to shock, we do have to stop chest compressions to do that. Do you see any downside in that?
I honestly don't think you have to really stop much to shock for compressions. You analyze it, which I think we're doing most of the time anyways, every 2 minutes, make sure you don't have ROSC on this patient. And then you can run with the Lucas and shock right through it.
Oh, interesting. So you're saying once you've analyzed it and you're like, oh, that's a shockable rhythm, you start the chest compressions back up, and then you can shock them while they're getting the chest compressions. Yep. And there's no concern, I guess, because you don't have anybody's hand on the patient.
You don't have anybody touching it.
And even if there was, I mean, I've seen studies where they've shown it's not that much if your hands are on it. No, that's actually super interesting. Now let's talk about drugs. So epi, right? You're doing epi. We do it here at LifeLink. We do an epi every 10 minutes instead of every 3 to 5. How many epi should I get in if I'm going to ECMO?
It really depends on the ECMO center, but I think a lot of them kind of do that cutoff around 3 milligrams or so. A couple different reasons. I think there's a lot of evidence. There are a lot of different theories out there about what the proper strategy of epinephrine is. Some other people in our metro area give 0.5 milligrams every 10 minutes or so. Some people give 0.3. Some give
drip.
Some give none in VFVT patients. I don't know what the exact science is. Maybe that's something that will come out about what the proper dosage strategy is. I do think probably some epinephrine is helpful for maintaining some vasoconstriction, especially in this profound acidosis, but making sure we don't get plus 5 milligrams, plus 3 milligrams. I think that's kind of where it becomes kind of futile at that point. And that's why a lot of ECMO centers do the 3 milligrams at that point.
Gotcha. All right. So, we've done our epi.
Yep.
We've done amio, you do your initial 300 and 150. Now I've had a couple patients that I have had, they're awake, right? They're not in arrest. Yeah. They are stuck in VTAC, and you shock them and you shock them, and you're cardioverting them. Yeah. And you're changing your vectors, and you can't get them out. And then you give them 2-4 grams of mag. And that seems to be the trick, that they were low in mag. And I don't know why that's the case. I don't know if there's obviously, if you have low mag, you have more of a chance of going into an arrhythmia. But do you recommend, if you're taking someone to ECMO, you're like, I don't really know what this is, right? This could be, most likely it's a coronary lesion that's led them to the situation. But would you say, is it in your practice to try a couple grams of mag and see if that helps?
That really isn't something I'm empirically doing in my practice, unless there's like a clear
dialysis patient.
Dialysis, like withdrawal patient, like those type of patients that you think that they could be hypomagnesic. But aside from that, I'm not regularly not regularly giving it, and I'm not regularly being told when I transport patients in for ECMO to give it at that point. And I 100% agree, like amio, epi, and everything. But I think the big thing to remember too is, and the kind of my big preaching point if you are transporting a patient to ECPR, is time matters. The AHA has now accepted ECPR for VFVT patients in systems that have ECPR programs, which are not super common across the country. It is a higher recommendation than amiodarone itself. So really still just keeping your eye on the goal at the end of transporting it to
forward momentum, constantly moving forward.
And the big thing of what's going to limit moving there is both like operationally getting the patient off the scene and doing priorities of treatment on scene and doing the rest en route, but also focusing on good high quality compressions and good high quality ventilations, because those, if you're not oxygenating and ventilating the brain or pumping on the chest well, the patient's not going to go on ECMO either way, and it's a mute point.
What's your feelings on Esmolol?
I think that was something that some people brought up and had some studies on that looked promising, but I personally haven't really seen a lot of people doing that very recently. I think that's the same thing of doing like certain blocks and everything for those refractory VT patients. I think it's definitely something that some places might consider and might do, but I don't think it has a lot of randomized control trials showing a good benefit out of it.
Theoretically, it makes sense. It's, beta blocker. You're giving epi not for the beta effects, but for the alpha effects. So, I wasn't sure if that's something that you've seen.
I've never really done that for a VFVT
And most ground crews are not even going to carry ESMO to begin with.
And I think for these patients where the ECPR centers, where this makes sense to transport somebody to an ECPR center, hopefully your transport time is going to be less than 20 minutes or so, plus 15 minutes on scene, dispatch, to be under that hour that most places like to get these patients in. I just think there's a lot of other things that are priorities over that, and that just takes some time to do as in the resuscitation.
Last thing I want to mention is the mechanical CPR devices. Obviously, when somebody first gets on scene, they should be doing manual chest compressions,
100%.
right? And my typical model with that is I do manual chest compressions and I'm watching my end tidal CO2, right?
Yep.
And a low end tidal CO2 is bad chest compressions until proven otherwise, in my mind, right? So, and I may have to find the spot, right? Like it's not always just the lower third of the sternum, right? Sometimes, and you've seen as well as I have with ultrasound, everybody's heart's in a different spot. Once I find that, putting some sort of indicator, whether that be a marker or something showing, hey, this is the sweet spot. So that way, if you do have another provider coming in to do chest compressions, they're not starting at a new place, right? But the other thing is when you put the Lucas device on or the AutoPulse or whatever you're using, I guess the AutoPulse is more of a band, so it's not as relevant, but the Lucas is a piston and I put it right over that spot, right? Yeah. Now you're moving them and you're getting up on the cot and you're getting them into the aircraft or the ambulance. What should we be using to make sure that our chest compressions are adequate and they're not, maybe this hasn't migrated. So yeah, you can look and make sure it's on that spot, but let's say you just got this screw handed to you and you're like, oh, I think that's the right spot, but I'm not sure. We don't really have transesophageal echo to know in the field to know if we're compressing the LVOT. Are you still throwing it on and just taking a look? Because I can sneak a parasternal long sometimes right next to the piston. What are you doing?
I think a couple different points I have on that. I think the locating the point, making sure you're not on the right ventricular outflow tract and making sure you're in a good place where you are not on the left, right over the left ventricular outflow tract, and making sure you're getting good compressions is extremely important. But it's another one of those things, if we're talking specifically about ECPR, it just takes time as well. That's, I believe, something that can be done en route to a hospital. It's also something that I think takes, it takes a provider really paying attention to it, right? That is a more advanced ultrasound skill and dictates one person for that. So I envision that more en route to the hospital and optimizing for during your optimizing time. So I'd just like to say that to start. But knowing that it's in the right place, kind of two things is there was good studies that showed in over 50% of patients, you could get a good parasternal long during active chest compressions, and make sure you're not over the left ventricular outflow tract or such. So that's what I'm primarily looking at. Also, if you have adequate people on scene while you're in those 32 pauses, getting a good subxiphoid view or an apical view can be beneficial too. More that subxiphoid view would probably be the more easier during a cardiac arrest as such, and also end tidal. But you got to be careful on end tidal, because the same study that showed the 50% successful acquisition of that parasternal long during compressions also showed that compression of over the right ventricle drew up higher end tidals versus decreased overall perfusion of the patient. So I think it's a difficult thing to do, especially without having TE or something like that, that gives you a great shot throughout. But I think more just looking at your overall perfusion of the patient and correlating that with your ultrasound imaging.
Yeah, I find the subxiphoid is fine if I'm just trying to see, do they have effusion, tamponade, overall activity? But it doesn't really tell me much, I feel, when it comes to the compressions. It's really difficult to get a lot of the time. And so I like if you think about the heart sitting like this, and you got the Lucas right here, you can get a modified parasternal long by shooting your plane from the side, right? And so the main thing I'm trying to look at that point is that left ventricular outflow tract to make sure I'm not hitting it. And I feel like I can get a pretty decent view. And this may be a whole nother podcast, but I remember for a while it was told, if you get a good parasternal long view during chest compressions, and you're not doing CPR in the right spot. And I'd have to disagree with that. I think you can, if you understand how that plane, that pizza slicer cuts, you can have those chest compressions going. And sure, you may have a little bit of artifact or something that you're seeing on there. But if you get that in there right by that probe and tilt it over a little bit, I feel like you can get a decent view. And so maybe we'll have to look into that later.
Yeah, no, I 100% agree. The one caveat I would put on that is just this is all great things, and ultrasound's very useful in cardiac arrest.
On the way to the hospital. Yeah,
On
yeah.
the way to the hospital.
Yeah.
And after optimizing ventilations and such and everything like that.
If you did not have an ECMO center to go to,
Yeah, 100%.
what would you do?
If I didn't have an
If you had no ECMO center, your only hospital, if you transport the patient there, they're just going to call the code.
Yeah.
Maybe they may take them to cath if you get a pulse back, but they don't want somebody dying in their cath lab. That looks bad. What would you do to optimize it right there at the house?
First thing I would do is make sure good ventilations, endotracheal intubation. I think that's really extremely important on these patients as well. And then trying to get them out of that rhythm while maintaining good perfusion. And that's both making sure the vector change to dual sequential defibrillation, going over the basic things like H's and T's, make sure it's not that dialysis patient who maybe has, some labs that are abnormal, and then locating the point where compressions are the best located on the patient.
Are you starting AP?
I am doing, AP right off the bat. I think the data shows that it's the superior location. There's a reason why every cath lab I feel like I brought patients to, if you bring them in for a STEMI, it's always
First
AP.
thing they do, yeah.
Yeah, always AP. It just provides a lot better, I think, delivery of energy right to that LV.
Awesome. Well, thanks, dude.
Yeah, no worries. Thanks.